Allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. Definition: the condition is probably an extension of IgE and IgG reaction to aspergillus, where the inflammatory response to the aspergillus in the airways leads to damage of the bronchial walls and bronchiectasis. Some authors reserve the use of term ABPA for when bronchiectasis is present. Others subdivide into ABPAS seropositive only in those with positive serology but without bronchiectasis, and ABPAB in between bronchiectasis. The prevalence of ABPA in asthmatic populations have varied considerably between studies and clearly will depend on whether the definition includes bronchiectasis or not. It probably occurs in about 1 to 2% of asthmatics. A related condition occurs in patients with cystic fibrosis, where it appears about 7% have evidence of colonization and potential ongoing damage. Pathophysiology: the factors promoting the evolution from atopic asthmatic to ABPA are not known. HLA associations have been shown, with interleukin 10 promoter alterations are associated with aspergillus colonization. Proteolytic enzymes are released by aspergillus as a part of its exophytic feeding strategy, and these enzymes may damage airway mucosa. However, most believe that the damage resulting from host defense mechanisms, septated hyphae rather than just spores, may be visible in the mucus and grown from sputum, but there does not appear to be actual invasion of the bronchial mucosa. This immune inflammatory activity produces mucoid impaction in the airways, eosinophilic pneumonitis, and the bronchocenteric granuloma formation. Main criteria for diagnosis of allergic bronchopulmonary aspergillosis: the first four are the most important. Skin prick over immunoglobulin E positive to Aspergillus fumigatus, immunoglobulin G to Aspergillus fumigatus, central proximal bronchiectasis, blood and sputum eosinophilia, then total serum immunoglobulin E more than 100,000 international unit per ml, and the last lung infiltrates, which are fleeting type. Other clinical features include long-standing asthma with recent deterioration, recurrent episodes of mucus plugging, fever and malaise, expectoration of dark mucus plugs, sometimes as castes of the airways, eosinophilia, sputum and blood, occasional hemoptysis, and the major complication is poorly controlled asthma that requires repeated courses of oral steroids. Investigations: spirometry, degree of airways obstruction, skin prick sensitivity to aspergillus immunoglobulin E, sputum aspergillus hyphae and eosinophils, blood include immunoglobulin G to aspergillus, immunoglobulin E Rust to aspergillus, total serum IgE, eosinophil count suppressed if on steroids, and the chest radiograph revealing flattening infiltrates, bronchiectasis, mucus impaction, that's to say, gloved finger shadows, computed tomography CT, central, which is proximal bronchiectasis with upper lobe predominance, management of allergic bronchopulmonary aspergillosis. The treatment goals are to stop progression to bronchiectasis or fibrosis. The management is essentially that of severe chronic asthma, but with generous use of courses of oral steroids. Several randomized controlled trials have been shown courses of itraconazole 200 mg BD for 4 months are well tolerated as an adjunct therapy, reduce steroid requirements, and improve exercise tolerance. There appears to be a sustained effect after the itraconazole is stopped, suggesting at least temporary eradication of the aspergillus. Response and relapse can be monitored with IgG to aspergillus. Itraconazole can cause liver dysfunction, so liver function tests need monitoring. Cases reports have shown a reduction in exacerbations of ABPA related to cystic fibrosis, but randomized evidence is lacking. The differential diagnosis of allergic bronchopulmonary aspergillosis. The, the differential diagnosis include the following: acute and chronic eosinophilic pneumonia, Church-Strauss and eosinophilic granulomatosis polyangiitis syndrome, various parasites such as filariasis, Ascaris, Lafleur syndrome, drug-induced eosinophilic pneumonia.